So, acute coronary syndrome is the next topic which we will discuss. It's a common thing which we get in emergency department. In ED, we frequently face a patient of acute coronary syndrome. So, what all we will discuss in this? We will discuss the assessment, we will discuss the epidemiology, we will discuss the transport, we will discuss the management. We will focus our discussion mostly what we do to these patients in emergency department, right? What is the acute management? So our major focus in this topic would be the focus on STEMI, that is ST segment elevated myocardial infarction, rather than the non-emergent one, non-STEMI, or the low risk one. We will leave for the medicine people to discuss. So what I will discuss in emergency medicine part of acute coronary syndrome, I would keep my focus on STEMI, that is ST segment elevated myocardial infarction. Okay, so let us come. That's a few things about epidemiology of this STEMI, of acute coronary syndrome. In emergency department, acute coronary syndrome is a common presentation, right? The mean age for this is 68 years, but the range is 55 to 72. And there is a male preponderance of 3:2. So in every 10 patients presented with STEMI, 6 would be male and 4 would be female. Though I must tell you, this mean age group is gradually decreasing. So index of suspicion should be very high in patients, right, presenting with chest discomfort, even if the patient is young, right? So index of suspicion should be very high. Okay, so 70% of the patient presents as non-ST segment elevation, means they don't have that massive acute MI, right? That is complete blockage of the coronary artery. And these patients, if they do not have a complete blockage, right, of coronary artery, they are like they have more subtle finding on ECG, right? They are not emergent cases. There is a blockage of coronary artery, but there is not a complete occlusion. So since there is not a complete occlusion, so they need a treatment, but treatment need not be time specific and emergent. So they are mostly referred to the cardiology, right? 70% of patients presenting with chest discomfort, having non-STEMI ST segment elevation, means they do not have a massive acute MI. So their management need not be time framed, right? Their management need not be time framed as in STEMI patients. Okay, so what is a definition of acute coronary syndrome? Definition is any condition, acute, any new condition that leads to inadequate myocardial perfusion relative to demand. That is any new condition which makes an imbalance between supply and demand of the blood to myocardium. So inadequate perfusion relative to demand, right? Now, patient with coronary atherosclerosis, the blockage in the coronary artery, may develop a spectrum of clinical syndromes and representing a varying degree of coronary artery occlusion. Depending upon the amount of coronary artery occluded, a varied amount of presentation may be seen in these patients. There may be a different kind of presentation in these patients, right? So depending how much of their coronary artery is occluded. Okay, the presentation spectrum varies from unstable angina to non-ST segment elevated MI to ST elevated MI, right? So unstable angina, non-ST segment elevated MI, ST segment elevated MI. So spectrum can be different. Now, unstable angina. Patient will come to the emergency walking with a history of impaired exercise tolerance. Patient will give you history like this, that doctor, when I walk for, let's say, few kilometers, I have a chest discomfort, right? Doctor, if I do household work right? I have a chest discomfort. When I rest, things are fine. But when I do some active work, things become difficult for me. I have a chest discomfort. So these patients, they are, when evaluated, they may have no ECG findings, and when the cardiac troponins are done, no elevated cardiac enzyme, no elevated troponins. So cardiac enzymes are also normal, and ECG finding is also normal, right? Definitely, these patients are high-risk patients, and they are shifted, they are sent to the cardiology for proper investigation and appropriate management. They don't need a time frame emergency management. Okay. Then we have non-ST elevated MI, non-ST segment elevation MI, right? Now, patient can have ischemic pain in any setting, even in rest, unlike unstable angina, which needs some activity. They need some activity for the pain, chest pain, to precipitate. Non-ST segment elevated MI, they may have pain on and off pain during exertion and also during rest. So they will say that yes, even when I am sitting, I have some chest discomfort, and when I do some work, then also I have some chest discomfort, right? ECG changes, they will have ST depression or T wave inversion. They don't have ST elevation, they have ST depression or T wave elevation, and their cardiac enzyme troponin would be elevated, right? Again, they have to be investigated properly. They are referred to cardiology for their further management, investigations and management. They again do not need a very time frame management, right? Now coming with our area of interest, that is ST elevated MI, ST segment elevated myocardial infarction. This is a classical acute emergency, right? This is a classical acute emergency, and we have to remember a very important point in this, that time is muscle. The management has to be time framed. The management has to be specific. The management has to be based on a logarithm. Management has to be mannered, right? So diagnosis and management needs to be started early for saving life, because remember, time is muscle. This is an acute emergency situation. There is a complete obstruction. I'll talk about that. The blood supply to the epicardial muscle is epicardial coronary artery is completely occluded, and muscle necrosis has started, right? So time survival depends on out hospital response, as majority of them die before reaching the hospital. What happens that complete occlusion of the blood supply to the myocardial, this results in ischemia, myocardial ischemia, to the particular area where the blood supply is reduced or has become zero, right? And because of those dying muscles, a ventricular fibrillation or pulseless ventricular tachycardia is precipitated, right? In most of these cases, complete occlusion, myocardial ischemia leading to myocardial infarction, and that infarcted muscle makes the electrical activity of the heart disorganized. The proper electrical activity of heart is not happening, and disorganized rhythm, heart goes into disorganized rhythm, and ventricular fibrillation or pulseless ventricular tachycardia, other rhythm which takes over normal sinus rhythm. Okay, so majority of the patient, they have acute chest discomfort, and if not timely managed, the area of muscle infarction develops, and this results in what does it result in? It results in improper electrical conduction in the heart. The electrical conduction of the heart becomes disorganized. Ventricular fibrillation and pulseless ventricular tachycardia, etc. can happen. It can happen. Now, most common cause of VF and pulseless ventricular tachycardia is acute coronary syndrome. That is ST segment elevated MI. So we need an good BLS, that is basic life support, and ACLS a timely BLS in these patients to bring these patients alive to the hospital. So the life of these patients depends on how fast the diagnosis is made, how fast the treatment is started, and how fast any complication, if it develops, is managed by the health personnel. Okay. Now, apart from the role of transferring these patients to the emergency department, there is role of emergency department, of course. There is a role of transporting of by emergency medical personnel to the emergency department. Before that, the most important role is of community. Community, there should be programs developed in community to respond to out-hospital cardiac arrest developed due to acute coronary syndrome. So communities, they have to be taught how to recognize the symptoms of acute coronary syndrome, right? They have to recognize that if a patient is having a certain type of chest discomfort, right, the patient can have acute coronary syndrome. So they have to recognize acute coronary syndrome and activate the emergency medical system very fast. They should know how to provide a CPR, because number of these patients have a complete occlusion of the coronary artery, immediate myocardial infarction, which may lead to ventricular fibrillation and pulseless electrical activity, leading to cardiac arrest. So if this happens, the community lay personnel around the patient should know how to give a CPR, how to give a early defibrillation. Ventricular fibrillation and pulseless ventricular tachycardia are the most common rhythm, as I told you. And they are defibrillating rhythm. They can respond to defibrillation. So early defibrillation, and system should be, there should be a coordination between emergency medical system, emergency department and cardiology for a definitive management. So there should be a very fast action. Community should make a diagnosis. Emergency medical system should be activated. Patient should be transported to the emergency department very fast. Emergency department should make the diagnosis and shift the patient for the definitive management to the cardiology. So all these things should be under fixed time frame, and then only their survival is possible in the patient, right? So time is muscle. We have to take care of time frames. What is the goals in these patients? Major goal in this patient for us is identification of patients with STEMI. That patients with STEMI, as I already told you, needs a time frame management. So those patients should be triaged, should be delineated from the non-STEMI patient, right? They should be triaged for early reperfusion therapy, right? Patients' chest discomfort should be relieved. Patients should be relieved of chest discomfort because it is further producing sympathetic stimulation and imbalance between the myocardial demand and supply, etc. Goal should be to act fast to prevent MACE. What is MACE? Major adverse cardiac events. So major adverse cardiac events should be prevented. And any acute life-threatening condition developing like ventricular fibrillation, etc. should be managed. These are the goals. Identification, that which patient should be triaged for early reperfusion therapy. Chest discomfort should be immediately relieved in emergency department, right? Prevention of MACE, that is major adverse cardiac events, and any event if develops, any acute life-threatening condition if develops, it should be managed accordingly, right? It should be managed accordingly. Okay, these should be the goals. So what we will discuss? We will discuss the management of acute coronary syndrome based on American Heart Association A logarithm, right? Based on the A logarithm of AHA, which we need to practice in emergency department to manage these patients. We'll focus on STEMI, ST segment elevated myocardial infarction. Okay, so what is the step 1? Step 1, whether it is community or it is in hospital or anywhere, is to recognize the symptoms suggestive of ischemia, chest discomfort, which is most probably due to myocardial ischemia. These symptoms should be identified. Now, the most common symptom of myocardial ischemia or infarction is retrosternal chest discomfort, right? Patient may not say pain, may not always say pain, right? Patient may not always say pain. Patient may say that a squeezing sensation or something like that. So retrosternal chest discomfort, any kind of retrosternal chest discomfort, not necessarily pain. Let's say you should have a high index of suspicion for acute coronary syndrome. Any retrosternal pain, high index of suspicion for acute coronary syndrome. Okay. Now, what are the other symptoms? Uncomfortable pressure of fullness, suspecting, let's say, squeezing pain. Uncomfortable pressure, fullness, squeezing or pain in the center of chest lasting several minutes, right? Then chest discomfort spreading to shoulder, neck, right? Arms, jaw, etc. Then chest discomfort spreading to back between the shoulder blade. Then chest discomfort with accompanied with nausea, vomiting, lightheadedness, syncope, any associated symptom. Have a chest discomfort with the associated symptoms, or acute shortness of breath. Number of time patient presents with acute shortness of breath also. We can suspect acute coronary syndrome in these patients also, right? Now, females then generally have an atypical kind of presentation of acute coronary syndrome. So, any chest discomfort, retrosternal chest discomfort, high index of suspicion. But any chest discomfort, squeezing or fullness or pain spreading to shoulder, blade or arms, jaw, etc. should all have high index of suspicion. No chest pain. The rule should be no chest pain should be taken lightly. Well, they always should be investigated, right? If there is no problem, it's fine. But if there is a problem, time is muscle. We have to take care. Time is muscle. Okay. So, if a community calls emergency medical personnel that some patient is having a chest discomfort, the response time should be very fast, very specific, and management should also be very ordered. So when emergency medical system responds, right, to out of hospital, they should immediately start assessment and action. Now, the first thing which the emergency medical system do, they start the monitoring of the patient and support the airway if it is required. If patient airway is not adequate, if oxygenation is being required by the patient, right, if breathing is compromised, then immediate support to these primary things should be done. So primary assessment, ABC, airway, breathing, circulation should be immediately taken care of, right? Monitor should be attached, airway should be supported, breathing and circulation. Always oxygen has to be attached in these patients with acute chest discomfort. Why? I will tell you the benefit of oxygen in my subsequent slides. Okay. Aspirin. If there is no major known allergy to the aspirin or recent GI bleeding, right, patient should be given aspirin to chew. Tablet of aspirin to chew. So chewing is better than swallowing. It has a better serum concentration rather than swallowing. So aspirin tablet should be given to chew. And if patient has a major GI bleed, etc., history of GI bleed, etc., or history of peptic ulcer, then a rectal aspirin can be given. Rectally aspirin can be given instead of oral chewable aspirin, right? So aspirin. NTG, nitroglycerin, sublingual NTG, NTG tablets can also be given to the patient. Sublingual NTG can be given to the patient. Morphine. I will tell you the relevance of all these drugs and when they have to be stopped and what is the role of these drugs. So if the chest discomfort is ongoing, NTG I am giving. Every sublingual tablet every 3 to 5 minutes till the patient is relieved of the chest discomfort. If the pain is not getting relieved, right, by nitroglycerin, morphine can be given in some of the patients after ruling out few things. Okay, and immediately the most important intervention, 12 lead ECG should be done. Immediately 12 lead ECG should be done. Okay, then so monitor and support of ABC is included. Monitor vital signs and cardiac rhythm. Be prepared to provide CPR and use defibrillator. So EMS should monitor ABCs, monitor vital signs, cardiac rhythm. Be prepared to provide CPR if in case required, and defibrillation. They should always be prepared to defibrillate, because most common rhythm in acute coronary syndrome, as I told you, is ventricular fibrillation or pulseless ventricular tachycardia. Okay. Oxygen. Why do we give oxygen to these patients? What are the use of oxygen? Now, high inspired oxygen tension will tend to maximize the arterial oxygen saturation, right? So blood will have a maximum oxygen saturation. When we are breathing room air, right, maybe our PaO2, right, is 90 to 100 mm of Hg. If I breathe 100% oxygen, it can become 600 mm of Hg or 800 mm of Hg. So I am maximizing the arterial oxygen saturation, right? In turn, the arterial oxygen content. So in case of imbalance, when less blood is flowing, that less blood is with more oxygen. I am making the oxygen concentration of the blood high. That less blood is with more oxygen. So oxygen delivery can increase, right? Oxygen delivery can increase. So every patient with chest discomfort, oxygen has to be attached. Even if the saturation is within the acceptable range, then also oxygen has to be started. Okay. Aspirin. Now, what is the use of aspirin? Why is aspirin given to these patients? Aspirin inhibits thromboxane A2 production by inhibiting the COX-1, that is platelet cyclooxygenase. It's a COX-1 inhibitor. So this platelet, right, is the most important and earliest principal participant in thrombus formation. Whenever there is bleeding, etc., thrombus plug is formed. Platelet is the main activator, earliest participant. So what I am doing? I am decreasing the platelet production by giving a COX-1 inhibitor. So what is the benefit? Well, number of times there is occlusion and there is the opening of the air. Then again there is a reocclusion, again the opening of the air, opening of these blood supply. Occlusion, then maybe there is little let's say opening of the occlusion. This opening of the occlusion can be maintained if the platelet production is decreased. So aspirin prevents reocclusion. Aspirin prevents reocclusion. Got my point? Okay. What is the dose? 160 to 325 milligram non-enteric coated aspirin to chew. Contraindication, as I already told, known allergy to aspirin and recent GI bleed, peptic ulcer, anything. Rectal aspirin suppository is given 300 milligram in case of GI disorders. If a patient has a history of peptic ulcer, a very quick history is taken, right? Okay. Then nitroglycerin. The other drug is nitroglycerin. What does nitroglycerin do? It reduces the chest discomfort. How? Reduction in LV and right ventricular preload. It causes venodilatation, both arterial and venous dilatation, peripheral arterial and venous dilatation. So what happens? That there is a reduction in left ventricular and right ventricular preload, both through peripheral dilatation. Preload is reduced. So what will happen? coronary perfusion will improve. But important is that you have to give it carefully in case of hypotension. If patient is in hypotension, etc., this can be deleterious. So you have to give it in presence if there is a blood pressure is within normal limit. So dose sublingual tablet every 3 to 5 minutes till patient chest discomfort is relieved. So sublingual tablet every 3 to 5 minutes. What is the contraindication? When we don't give this NTG, nitroglycerin. If there is suspected inferior wall MI or RV infarction, if the sign and symptoms of the patient is pointing towards RV infarction, or we have done a 12-lead ECG and inferior wall MI is suspected by the ECG. Inferior wall MI or leading to RV infarction, right? There, the cardiac output is preload dependent. It is dependent upon the preload, how much there is a filling of the heart. So if I reduce the preload, patient will go into decompensated shock, very difficult to manage. So NTG is not given in case of inferior wall MI, RV infarction. Okay. Hypotension, bradytachy, any condition, right? Hemodynamic imbalance, patient is in hypotension, there is a bradycardia or tachycardia, we avoid giving NTG. And if patient has taken a recent phosphodiesterase inhibitor like sildenafil or something like that, any tablet, phosphodiesterase inhibitors, right? So if patient has taken a phosphodiesterase inhibitor, right, they are the drugs which are used in erectile dysfunction, etc. Then these drugs, phosphodiesterase inhibitor and NTG, they both can lead to severe hypotension refractory to the management. So hypotension can exaggerate. So in case of there is a drug interaction between these two, phosphodiesterase inhibitor and your NTG, so hypotension, refractory hypotension can happen. So we don't have to give NTG in these three conditions. Okay. Now, if this chest discomfort is not getting relieved by NTG, then we can give morphine. Right? This morphine has a few important rules apart from reducing chest pain. It reduces chest pain, that is discomfort of the patient. But you have to give it, it has some other additional benefit also. But you don't have to, it is contraindicated in non-STEMI. In non-STEMI chest pain, we don't have to give morphine. It is only indicated for STEMIs, ST segment elevated MIs. Apart from relieving chest pain, it has a sympatholytic effect. It causes venodilatation, right? So decreases LV load, oxygen requirement, right? Both. It decreases the oxygen requirement of the heart, decreases left ventricular afterload because of venodilatation, right? So all these benefits of the morphine decreases the chest pain and do an overall benefit to the patient. Plus, if a patient develops acute pulmonary edema post MI, then morphine helps in redistribution of blood from pulmonary to systemic circulation, and pulmonary edema to some extent is decreased, right? So morphine has multiple roles. Okay, let us say, so this patient was shifted from his home to the emergency department. Let me build up a case scenario that a person was gardening and suddenly had a chest discomfort. His wife noted it, activated emergency medical system, meanwhile making him sit down on the chair. The emergency medical system came over. They assessed the patient for the symptoms, and when they took the history, the patient complained of chest pain. They suspected acute coronary syndrome. Immediately, they attached oxygen to the patient, gave aspirin to the person to chew, asked the person to chew the aspirin, right? Or after taking a quick history of aspirin allergy or recent GI bleed, etc. Then started giving him sublingual NTG to relieve the chest discomfort. Did a 12 lead ECG, and if they have acumen to recognize the ECG to between STEMI and non-STEMI MIs, distinguish the ECG or read the ECG, if they have acumen to read the ECG, and if they can identify the ST segment elevated MI, they will immediately inform the hospital that they have a patient of acute coronary syndrome, right? And most probably it is STEMI, that is ST segment elevated MI. They will activate the hospital, right? Now, patient is received in emergency department. Within 10 minutes of receiving the patient, right? A primary assessment is done. Vitals are checked, oxygen is attached as it was, or if it is still attached, it is already attached by emergency medical system transporting the patient, it is kept attached. IV access is let's say secured, and a targeted history and a physical examination is done. A very brief targeted history, right? What I discussed, sample, sign and symptoms, right? A sample history is taken, that is S for sign and symptoms, right? Then A for any allergies, M for medications, right? Last meal taken by the patient, and then events, right? So our targeted history is taken, physical examination is done, right? And a very fast review of fibrinolytic checklist is done. If patient needs to be fibrillized, fibrinogen has to be given for a clot disruption, right? There is a occlusion, there is a clot which is making the blood flow to the heart muscle impaired. A clot disruption, fibrinolysis has to be done. So an immediate checklist for the fibrinolytic, complete checklist is done for fibrinolysis. Cardiac marker levels are done, that is cardiac enzyme is monitored. Electrolyte and a coagulation profile of the patient is done. And if possible, a portable X-ray is done, right? If not possible, it is left down. So within 10 minutes, less than 30 minutes, assessment is within 10 minutes and all these activities are finished within less than 30 minutes. So everything should be within the time framed zone, right? Assessment, vitals, oxygen, IV line secured, targeted history, physical examination, fibrinolytic checklist, cardiac enzyme measured, electrolyte and coagulation profile sent. Okay? Okay. Now, if the emergency medical system during transport has done a 12 lead ECG, immediate interpretation of the ECG has to be done. If not done, then when the patient comes in the emergency department, right, whatever is left during the transport, emergency medical system, whatever is left, what are the things which they have to do? They have to attach oxygen, give aspirin, NTG, morphine, and do a 12 lead ECG. Anything of this has been missed, it is immediately done in emergency department, right? Anything missed is immediately done in emergency department. That is, oxygen is applied, aspirin is given if not already given, NTG given if chest discomfort is continuing, right? 12 lead ECG is done, and immediately 12 lead ECG has to be interpreted, right? 3 interpretation can be there: STEMI, ST segment elevated MI, that ST segment is elevated, non-ST segment elevated acute coronary syndrome, ST depression, or inverse or dynamic T wave inversion may be there, ST depression, or nothing significant in ECG, lower intermediate risk acute coronary syndrome, normal ECG, right? Maybe patient doesn't have acute coronary syndrome, chest discomfort due to some other reason, so they are low or intermediate risk patient. Okay. Now let us talk about STEMI, ST segment elevated MI. This is our main target and this is what we have to manage. What is the characteristic of STEMI? ST segment elevation in 2 or more contiguous leads, right? In 2 or more continuous lead, there is a ST segment elevation or a new appearing left bundle branch block, right? Threshold value, the J point of the elevation, greater than 2 mm in lead V2 and V3 and more than 1 mm in all the other leads, right? J point is elevated greater than 2 mm in leads V2 and V3. I'm not going in detail of ECG. I expect that you know ECG from your medicine lectures. So what I'm saying, that the J point elevation greater than 2 mm in leads V2 and V3 and 1 mm of more in all other leads or new left bundle branch block. Okay. So you can see this ECG slide for recognizing the ST segment elevation. So ST segment elevated MI. So ST segment is elevated. The J point is more than 2 mm, right? In 2 contiguous lead. You can see this. The ST segment is elevated. It is not touching the baseline. The blue line shows, the blue arrow shows the ST segment elevation. This is ST segment elevated MI. Patient is having acute chest discomfort, and in ECG we have a elevation of ST segment, right? Now, so what is this indicating? ST segment elevation is indicating what? A complete occlusion of epicardial coronary artery. And what is the main management? Timely reperfusion. Complete occlusion. So ischemia has started. It will lead to infarction, irreversible damage of the cardiac muscle. So we have to do a timely reperfusion. Before that, ischemia becomes infarction. So early fibrinolytic or percutaneous intervention, right? Fibrinolytic or percutaneous intervention we have to do. You know, timely reperfusion has reduced the mortality by 47%. And there is a study which has shown that if within 1 hour of chest discomfort, a fibrinolytic is given, then a 47% reduction in mortality is seen. There's a reduction in mortality of 47%. Okay? Now, so what are the 4 Ds of ST segment elevated MI? Door, data, decision, drug. Door from patient house where he is having chest discomfort, right? Patient from door is taken to by emergency medical system and 12 lead ECG is performed at the timely interval. The data, 12 lead ECG is performed at a timely interval and the data is interpreted and a quick decision is made. ST segment elevated or non-ST segment elevated or low or intermediate risk. And after decision, the drug is immediately given. So door, data, ECG, that is door, that is patient symptoms, then data, quick ECG done, then decision based on that ECG, and then drug given, the fibrinolytic, the reperfusion drug given to, should the time between these should be minimized. Because remember, time is muscle. We have to minimize the times, right? So time frame for reperfusion. What are the time frame for reperfusion? For percutaneous intervention, door to balloon time. Door means, what is the door? Door is emergency department when the patient has entered. That is door to balloon time. Patient has come to the emergency department to percutaneous dilatation by balloon. Percutaneous intervention should be done within 90 minutes. Okay. So door to balloon time, the target time frame is within 90 minutes. Fibrinolytic, right? Door to needle, I will attach IV and start giving the fibrinolytic agent, should be within 30 minutes. And ineligible for fibrinolytic, if patient is ineligible to fibrinolytic and let's say the center doesn't have facility for percutaneous intervention, doesn't have a cath lab to do a percutaneous intervention. The transfer to percutaneous intervention should be done within 30 minutes. Patient of chest discomfort, that is, has come to the emergency department. Emergency department has done a ECG, data, seen the interpretation, and made a decision that this is a ST segment elevated MI. Right? Done a quick checklist of fibrinolytic checklist, and patient is not suitable for doing a fibrinolysis, giving a fibrinolytics. Right? So immediately, within 30 minutes, patient should be shifted to a center where cardiac catheterization can be done. Cath lab is there. Percutaneous intervention can be done. If patient is a candidate for fibrinolytic, then immediate fibrinolysis should be started. But if patient is not a candidate for fibrinolytic, then patient should be shifted. Patient should be shifted. Right? Okay. Now, management of ST segment elevated MI. Percutaneous intervention. The most commonly used form of percutaneous intervention is coronary intervention with stent placement. This is the management of choice. This is the management of choice. Percutaneous intervention, if possible, is the definitive management of ST segment elevated MI and should be done immediately. It is preferred over fibrinolytic. It is preferred over fibrinolytic. It is treatment of choice, as I said. Within 90 minutes from first medical contact, the percutaneous intervention should be done. Right? If a center has a cardiac cath lab, entering the patient has come to the emergency department door, patient within 90 minutes, the percutaneous intervention should be completed. Right? If the center doesn't have a cath lab, then the time frame has been increased from 90 to 120 minutes. Right? Within 120 minutes of the first medical contact, if transfer is required, patient is transferred for percutaneous intervention. Right? And patient who cannot be given fibrinolytic, contraindicated for fibrinolytic, again we only have to do percutaneous intervention. So what are the indications? What are the indications of percutaneous intervention? It is treatment of choice. Every time it should be preferred. So within 90 minutes, if I can give a percutaneous intervention, I can do a percutaneous intervention of first medical contact. It is first thing which we do. If the center doesn't have the capability of cath lab, then within 120 minutes, if I'm shifting, and within 120 minutes, the percutaneous intervention can be done. Again, we have to wait and get the percutaneous intervention done. And if the patient is not a candidate of fibrinolysis cannot be done, then only thing which we can do is percutaneous intervention. Right? Now, okay. Now, let's say the second management is fibrinolysis. Now, the fibrin specific agent should be used. Right? That is recombinant tissue plasminogen activator. Recombinant tissue type plasminogen activator, alteplase, etc. can be used for fibrinolysis. Right? Now, what are the inclusion criteria? What are the patients in whom fibrinolysis can be done? In absence of any contraindication, which I will discuss in the exclusion criteria of fibrinolysis, if within 12 hours of presentation, first symptom, we always collect the data when the patient was fine before the chest discomfort. So onset of presentation, if within 12 hours, right, in absence, patient doesn't have any contraindication for fibrinolysis, then patient is a candidate for fibrinolysis. After 12 hours, not recommended. But if the chest pain is ongoing, if patient has a continuous chest pain in spite of giving NTG or morphine, etc., patient is having ongoing chest pain, then again, even after 12 hours, right, the fibrinolysis can be attempted. Okay? What are the exclusion criteria where we don't do fibrinolysis? If patient has a history, I told you that emergency department during transport, or when the patient arrives in the emergency medical system during transport, or when the patient arrives in emergency department, a quick fibrinolytic checklist is done. Right? what are the things which we need to ask? If patient has the significant head trauma or prior stroke in previous 3 months, I can't go for fibrinolysis. Arterial puncture at a non-compressive site in previous 3 months. Any arterial puncture at non-compressive sites. History of previous intracranial hemorrhage. Any history of previous intracranial hemorrhage, we don't do a fibrinolysis. Elevated blood pressure. If systolic blood pressure is above 185 and diastolic blood pressure is above 110, we avoid fibrinolysis, right? Active internal bleeding. If patient has any active internal bleeding. Active bleeding diastasis. Patient is on anticoagulants. Patient has a platelet count less than 1 lakh, right? mm cube. Then heparin, patient has been given heparin within 48 hours and APTT is prolonged. That is, patient is on anticoagulants with INR more than 1.7 or prothrombin time more than 13 seconds. These all are contraindications for fibrinolysis. Or blood glucose less than 50 milligram per deciliter. And in CT scan, if a quick CT scan is done, there is multilobular infarction or there is a history of any infarction in these patients, multilobular infarction, then again it is avoided. No, it is not done, right? Fibrinolysis is not done. So these are contraindications of fibrinolysis. Treatment of choices, percutaneous intervention, right? If we cannot do percutaneous intervention within the required time frame, and if patient doesn't have contraindication for fibrinolysis, then fibrinolysis can be done, right? Fibrinolysis can be done, right? After fibrinolysis, patient is shifted to the center where percutaneous intervention, the definitive management can be done, right? Okay. Apart from these two main management, the other adjuncts are heparin can be given to the patient, but not to the patient who has been given the thrombolytic. Then we have the role of biliverdin, then IV nitroglycerin, beta blockers, and glycoprotein 2B and 2A inhibitors, right? They have the roles which you must have studied in medicine, but this is not given in, let's say, emergency department. This is given more in a cardiac care center. Okay, we are more concerned in emergency department of timely diagnosis of STEMI, right? When the patient reaches the door of emergency department, immediately a quick history and evaluation is done. Required medications are given to the patient. A 12-lead ECG is taken. Data is collected of first symptoms and the time period is calculated. ECG is interpreted. A decision is made based on ECG and immediately the drug is decided whether patient would be going for PCI, percutaneous intervention, or a thrombolysis will be done to the patient. Fibrinolysis will be done to the patient, right? So, door, data, decision, drug. The 4 Ds which are required for managing a patient with acute ST segment elevated myocardial infarction. Okay, so thank you.